Live from the SABC's Auckland Park studios, welcome to this evening's episode of The Watchdog. My name is Vuyo Mvogo. On the show this evening, we have the government's chief advisor on Covid-19. Professor Koleka Mlisana talks us through her incredible journey before and after taking over from her colleague and friend Abdul Karim. Later on, we'll also speak to the South African Medical Research Council and the National Funeral Directors Association about the country's death rate. The Watchdog starts now. Let's welcome Professor Koleka Mlisana. Prof, good evening. Thank you so much for agreeing to talk to us this evening.
Good evening, Vuyo. Thank you very much for inviting me, and good evening to all the viewers.
Well, I mean, when you took over from Professor Karim about 100 days ago or so, the third wave was not with us. It must have been a baptism of fire for you.
Oh, yes, big time. Well, I mean, even the request to be the co-chair of the MEC for COVID, it really was a surprise for me and overwhelming responsibility, especially because, we all knew that COVID, was really going to be with us for a while. And so it really was. And the fact that we're now in a third wave, as you correctly say, it really has been, baptism of fire indeed. Lots of challenges, especially during our time in our country with everything that happened last week as well. Mm-hmm. So it really has not been easy.
Mm-hmm. Talk us through the past 3 months, if you will. Take us back to your first meeting as now co-chair of the advisory committee.
Well, I think for me, it actually starts from the day that Professor Abdul Karim gave me a call. And you need to remember that actually I have worked with Slim, for more than 10 years at Caprisa. Mm-hmm. So, he's a friend and a colleague. So when he called me and he was telling me that actually he is going to be stepping down because he had really committed to just a year on, to chair the MEC. And so he was then telling me that he really thinks, in fact, he's going to propose my name to the minister. Mm-hmm. And obviously I said to Steve, no, you're not going to do that to me. But anyway, that's history now. So I then, got the minister did speak to me. And like I was saying earlier on, I think for me, it really was, I felt it was firstly a great honor, but secondly, a huge responsibility. But I think what really just gave me the strength and confidence was knowing that, it was not just going to be about me, but I was actually going to be co-leading a group of, of great people, experts, of the country in their own fields, whether it's at clinical level, epidemiologists, modelers, socio-behavioral, sometimes. And so really one was coming into a team that really is one of our, best in the country. And so it was not really just going to be about me. And there was already a year where Slim had actually been and done a great job. So there were processes already in the decision-making, how we crafted the advisories, how we were asked to do advisories. So really for me, it was a matter of how then do I take this forward, to the next level. And it really has been, I must say, we're working very well. And I think we are all enjoying each other and we are respective of our own areas of expertise, which for me, then talks to great teamwork. And we really have managed to work together as a team thus far.
Have there been instances where you felt a great deal of peer pressure, perhaps, given that, you are working, as you say, with people who are experts in their respective fields?
I think what I have enjoyed in the team, like I say, has really been respect for each other, and also the fact that We understand what are our areas of expertise. I really have not felt peer pressure, even maybe, because even with decision making. So I've always been a person who is consultative. What does everybody feel? But at the same time, know when to then make the decision when a decision is to be made. So I think that has helped us. I really have not felt, negatively, at all, since I joined the team.
I know it's perhaps a difficult thing to do, but how would you rate your own performance as the body, as that committee? How would you rate your performance in terms of how you've managed this third wave?
Firstly, really, what I have seen in the MEC, it has been a group of very dedicated individuals, people who really are passionate about South Africa and her people, people who will really work. Like, for instance, when we need, if we're asked to produce an advisory, people will actually be able to get things done in such a short space of time under so much pressure. And I think the other thing that we need to really appreciate is that the majority, actually, maybe just one or two individuals, within the MEC, and I'm sure the other, advisory committees are the same. We all have got our day-to-day, what you call your, 8 to 5 jobs that we do. So really being in the committee is over and above that. How have we performed? I would like to think we really have tried our best, given the circumstances and also the challenges in sometimes exploring what then is science saying and how do we then, advise against so many other things that need to be taken care of. And really what we have made sure that we do is to get as much, advice, as much information, even from other experts within the country, because obviously there's no way we would think we are it and all, but we really have managed to create these, what we call technical working groups, where we will draw in expertise, from anybody that we know in the country. And we really have tried to put our minds together and given it the best shot. I suppose how we have fared, we probably would not be I wouldn't be the person to say that. The country has got to be the judge and not us, really. But all that I know is that we've looked at what data is available, what is the science, and what then do we feel should be done depending on whatever circumstances, whether it is a third wave, whether it is, what's going to happen, what should be happening to schools. We really have just tried to apply our minds based on available information and data.
Take us through very briefly that one meeting that you had before the president, which then gave rise to the president deciding to address the nation about the third wave. What was foremost in your minds at that time?
All right. So I think, firstly, everybody in the country, we could see that we were going to get to the third wave. Because, all the signs were there. We also had experience from the first and the second wave. And so we could see the numbers starting to increase. But I think what then happened was, especially now that we've already got, a lot of data, and we've developed a lot of expertise, even with modeling. So the modelers, they were busy trying to predict, to see when is it going to happen. And the biggest question really that was facing us was, as the numbers are starting to rise, especially when they started to rise in the Gauteng province. And, I remember, I think it was within a few days, 2 to 3 days, there were these steep rises in numbers of cases, new cases in Gauteng. And the question that we all were asking ourselves, what is actually happening? What is driving these high numbers? Is it because people are now fatigued and they really are no longer, adhering to non-pharmaceutical interventions? Have we reached what everybody calls, COVID fatigue? What is actually happening? Have we been lax, like we saw what was happening in India before? Or might there be another driving factor? And at that time, we didn't know that we actually had a new variant that was driving the pandemic. So when we then got the results of the sequencing of some of the samples that had come in, May and starting to, beginning of June, especially the first results that came out, they were coming out from KZN, and they showed that actually we had the Delta variant. And I think that's where we realized that actually, and understanding the characteristics of the Delta variant, that's when everybody then really got very worried and concerned, because we knew how highly transmissible this was. And it therefore meant if we were to do anything to actually make a difference, we would need to ensure that we stop whatever movement that there is, especially we had seen all these high numbers. So really there was that. And there was the fact that now we've got a highly transmissible variant. And secondly, it was also at a time where we had seen the high numbers in Gauteng, and we were beginning to see the health facilities, and were worried and concerned whether they were going to cope with the numbers that would come in for hospitalization. So really, those were the issues that were of great concern to us, especially because we actually had seen this and we had predicted and we had said we need to get the programs ready. We need to get this resurgence or surge, plans up and running. Do we have enough capacity? Are there enough beds? Do we have enough oxygen? And at that time, we were not getting a sense that this was actually happening. And so really, that's where we were at that point in time.
Oh, but were we prepared, though?
For Gauteng, initially, we did not seem to be prepared. I must say that, because you remember there was a phase where, it was felt that, the hospitals were running short of beds, and we kept saying, where's the plan? Where are where are all the other hospitals that were erupted, the previous, during the previous waves? What about staffing? Do we have enough staff? And so really, I think when it hit us and the numbers were quite high, we were really not as prepared as we should have been. As a result, the provincial Department of Health was really only able to come in, a few days, probably a week into, the high numbers that we were seeing, to say, okay, yes, this is what's going to happen. We then got a full plan. So we really could have done better. But at the same time, this was now for Gauteng, because it was the first province that really, had the, where we saw these high numbers. But at the same time, that then did alert the other provinces to say, hey guys, you can't do like what has happened in Gauteng. You better make sure that you've got your act together. So in a way, we could say we could have done better for Gauteng, but I also would like to believe that it also woke up the other provinces, should they have been in the same environment as well.
What were the answers when you asked why people weren't adequately prepared? Because this is what everyone was asking, why were people not prepared? Why were these hospitals, why were they left, in desolate conditions? Why were we so unprepared?
Well, really, truly speaking, Vio, is that, when you ask those questions, especially at such a time, you never really get the answers, except that people will then come up with plans to say, yes, this is what we're going to do. And you're asking yourself, couldn't you have done this last week? Why are we only talking about this today? But I mean, you don't really get answers, in the true sense of the word. Because I remember at one of the meetings, where we were then, the outlining of where the healthcare workers are going to be coming from, and that money was going to be made available. And the concern that we have was, we do know that it takes a while to actually recruit staff. How are we going to do this within, the short space of time, which we don't even have? But anyway, like I say, there really weren't clear answers as to why we were not, in the first place.
Mm-hmm. Now, the president should address us pretty soon. The first 14 days at first, which was, of course, extended. And as things stand, we're not, doing particularly well. What are you going to advise him?
Question. Well, really, obviously, I mean, we have to look at what has been happening. And I think if one can really just look at where we are right now, is that, everybody can see that actually we reached the peak of the wave. I think it was around beginning of July. I think the highest numbers for this third wave we saw on 4th of July. And where we had about 19,900 cases on that day. And when we compare that to the peak that we saw in the second wave, where it was just over 19,000. And I mean, fortunately, the peak really was not very different from the previous second wave. So, and since that time, we have seen the numbers coming down. I was actually just looking at the numbers earlier on, where you're finding that, if we're looking at the 7-day average, when we were around the peak, around July, Gauteng alone was seeing more than 10,000 cases on the 7-day moving average. But if we're looking at today, we are anything between 5 and 5,500 in Gauteng. And we have seen a gradual decline. And in fact, looking at even, there was a phase where Gauteng was accounting for almost 60% of the new cases each day. Now we are down to 35%. And we have seen an increase in the Western Cape, because now Western Cape is second in line. I think it's sitting at about 22%. So there has been a definite a decline in the number of cases. But what we need to keep in mind is that even though there's a decline in the number of cases, the hospital admissions are still increasing. I think where we have started to see some decline in hospital admissions is only just in Gauteng. So we are still going to see the increase in hospital admissions, and deaths still continue to rise. And we know this. But so what it therefore means is that there has been a turnaround. And so it probably is a time where then government can explore and see whether we should not have a review of the current level of restrictions. And so whatever advice we will give the Minister of Health will really be based on the data that we're seeing. But at the same time, we do want to caution everybody, because we've had the unrests last week. And in fact, when we're looking at the number of cases, it has been very difficult to predict what is going to happen, especially for KZN, because the impact of the unrest in KZN really dropped the level of testing drastically. And also whether then all the events that were happening last week are going to end up being, sources of increased transmission. So we really have been waiting to see this week. But I must say the increase in numbers, we are not seeing as much. And so really it looks like we probably, as far as the third wave is concerned, are out of the woods. But at the same time, like I say, the hospitals are still increasing, admissions are still increasing, and deaths are still to increase. And what for us as a committee becomes critical is to ensure that people will stick to using non-pharmaceutical interventions in case last week's events are going to end up as super spreader events. And secondly, what becomes critical is that we really want to see the vaccination program taking off, and it seems to be doing that just looking at the numbers, within the last week to a few days.
Are you happy with what you are seeing on that front, on the vaccination front?
Right now, I think we really are doing a lot better. It's just that, we've got just so much ground to cover. So, if one just looks at, we have been concerned, which is still a concern, about the rate of registrations. But if you're looking now at the under 35s, there really has been a hype, and it looks like, we're getting a lot of registrations coming in. And so we are going to see a lot of vaccinations, happening. In fact, I think I was looking, we're now more than 6 million people have been vaccinated. It's still a long way to go. And remembering that, even though with the more than 6 million that has been vaccinated, it's only, I think, 2.2 million that actually have been fully vaccinated, wherein people have had their 2 doses of Pfizer, and those that are receiving, Johnson & Johnson have had their single dose. So we still are away, we are still very far. And I think that takes us to just above, if even, around 3% of the population that needs to be vaccinated. So we're still a long way to go.
Now,
but at least there has been a significant improvement.
Now, SAPRA is, of course, looking at other vaccines to bring on stream as well. How far do you think they are in approving other vaccines?
What SAPRA always reminds us is that, their process of vaccine approval is really driven by the companies that want to bring the vaccine into the country, because it's those companies that would actually apply to bring the vaccine. And so whatever they will review, it will be based on who has applied. And thus far, I know, for instance, we recently heard that Sinovac has just been approved with the conditions that it was approved with, but also they are currently reviewing other applications. What one realizes, and I think this is what everybody realizes, is that actually we really have got to do these reviews, make sure that they are done thoroughly and properly, but ensure that within the specified turnaround times. So I really have no reason to think that SAPRA would delay in any way, but it really just depends on what has been put on their table, and otherwise we then will hear from them how soon those approvals are going to come through.
So I was going to ask you about ivermectin as well, because it's gotten people talking lately. You may have seen a couple of doctors who are asking or prescribing it for their patients. I want you to take a listen to a clip from one of those doctors.
It's Pinky Ngakaninqula here. Start ivermectin as soon as possible. Do not wait for your doctor to prescribe it, because some doctors are resisting it. They do not want to use it. The dose for treatment is 0.5 milligrams per kilogram body weight if you're taking the pill. I want you to memorize this, because when you go to your doctor, tell him what your weight is, and by then you should know what dose you ought to be getting. Do not allow a dose that is less than half of your body weight when you're taking the pill. I want you to do this and to be confident that you're doing the right thing for yourself, for your family, and if you take it early, it's going to reduce the viral load. It is going to reduce your spread, the spread of infection. It is going to flatten the curve, which is what we have been lamenting all throughout the past 2 waves. Whatever we have not done correctly in the first 2 waves, we're going to get it right this time around.
Your comment, Prof? She's a medical doctor.
I'm laughing, actually. Yes. No. And actually, I know her very well. She's a friend of mine. So I usually say this, that firstly, I am not a clinician. I don't see patients. And so insofar as ivermectin is concerned, my take has really been to look to see what the studies are showing, what the data is showing, and also to really rely on the reviews that are coming up from the groups within the country that always review medicines. And so if one looks at the data and one looks at the trials and studies that have been looked at, really there has not been a convincing, results that ivermectin really does work. Firstly, because of how these studies have been designed and how they have varied as well, even in the sizes, even in actually defining what the outcomes are going to be. And so really it becomes very, very difficult. And in fact, even as soon as I think it was last week, the response and the review report that came from NEMLEC was that really there is no evidence that shows that ivermectin works. And so why I said earlier on, I am not a clinician, and also the current, approval by SAPRA. And as a result, I then say, insofar as the advice that has gone to government, it says it is not currently recommended. But at the same time, the clinicians, they are the ones who are seeing the patients. And I suppose you then have to leave that decision to them. That really would be my stance. But insofar as science is concerned, it is not showing, that there's, as a result, there are a lot of studies that are currently underway. And one is hoping that we can get, those results coming through, and this matter can be put to rest once and for all.
In fact, a colleague of mine sent me a message from a neighborhood WhatsApp group, and apparently the person who sent this message is a doctor who works for one of the big hospital groups, who, after seeing patients, says most of these patients have been taking ivermectin, which was prescribed by doctors, and as a result, they feel falsely protected. I have lost 5 patients due to liver failure from ivermectin, and all patients currently admitted here have all been on ivermectin. Clearly, this drug does not work and is not intended for use by humans. I strongly encourage you to stop prescribing it and advise against the use of this drug. Currently, there is no prophylactic medications available for COVID-19 except vaccination. Yes, Prof?
Yes.
Okay, we seem to have...
I was just going to say, right now, at the moment, honestly, I fully agree with that doctor friend of yours to say, at the moment, what we have, what we know does protect against severe disease and death, it is vaccination. And that's why it's important as a country to make sure that we ramp that program up as quickly as possible. Because really, as of today, that's the only way, that's the only mechanism to prevent morbidities and mortalities from COVID-19.
Mm-hmm. Doc, I want to speak to you very briefly as we wind down about your other interest, which is tuberculosis and people living with HIV. A couple of weeks ago, I had the General Secretary of the TAC, and I want you to listen to part of what he said when he was here, because they feel, people living with HIV feel that they are being sidelined, and we've shifted away, our focus away from their own needs. Take a listen to what Mr. Yawa had to say during that interview.
If these working relations that we have with government do not work to improve the conditions on the ground, there is no need for us to continue with relations that do not serve the interests of the people. At some point, Vuyo and the people of South Africa, as TAC, we will reach a point now where we say, let us stop now. Let us speak the language our government and officials understand better in order for them to be able to respond to the needs of the people on the ground, to the needs of the majority of the public healthcare users. But now we are trying by all means to be civil. But at times there are those officials within the government who are pushing us to that corner where we will decide to take it to the streets. We don't want to take it to the streets now. We want to engage because we have been accused as TAC to say we like to use the media while you don't engage with us. And now we are engaging, but we don't get a commitment. To have a meeting, Vuyo, with government officials and not have commitments and not have timeframes on how those problems are going to be resolved is just like not having a meeting. We need to be taken serious. And the only way to be taken serious is only when the officials of government comes and sit down with us. We identify the problems, we present to them, we agree how are they going to be resolved, when. And when that is not happening, they must know that we are the citizens of this country. We are products of the liberation struggle of South Africa. We are the voters of this country. And if the situation pushes us to go back to civil disobedience, the officials of government and government must know that it is not of our own making, but it is because of what they do and how they treat the public healthcare users.
The General Secretary of the TAC, not a very happy man. You can hear the frustration, from the language he uses and how and he was speaking. And just for a bit of context here, this was on the back of a third report, provincial report, that they had compiled, where they were talking about not being serviced at hospitals, no capacity there, people not getting their the medicine that is supposed to sustain their lives. What has been your experience? Because I know that this is a big area of your work, and you're passionate about it.
Yes, thank you for that, Vuyo. Yes, definitely, I am. In fact, I do sit on the board of South African National AIDS Council, and where specifically, as a country, is to look at the response to HIV, to TB, and to sexually transmitted infections. And because, I have actually done a lot of research in HIV and TB lately, as well as STIs. And what we do know, and this has been documented already, is that when COVID, the pandemic, came in, there was a definite competition of resources, and to an extent where we did, as a country, shift priorities. And I think we need to actually acknowledge that, because we saw that, especially, with the lockdowns, firstly, the impact that this had on TB and HIV services was that when then the lockdowns came in, there was a definite reduction in the usual TB and HIV testing. Now, there are two things, that would have contributed to this. Firstly, it was the fact that with lockdowns, mobility was reduced, and so access to healthcare facilities where people would have come otherwise, whether to come for testing or to come to collect their medications, that was significantly reduced. And secondly, we saw a lot of healthcare workers who were also infected, with COVID. And so there was a huge strain on healthcare facilities. But over and above that, even on the testing side, because we were able to ramp up COVID-19 testing because of the infrastructure that was already there for TB, which is Gene Expert. Today we talk about doing the Gene Expert testing for COVID, and those machines, that equipment we had been using for TB testing, as well as even, measuring the HIV viral loads. We're using the same platforms for COVID. So there was that competition. And in fact, like I'm saying, this has been documented, where we really have saw that if you're looking, there was almost up to 50% decline in testing for TB, and for HIV, I think we're sitting at around 33% or so. So really, there was a significant drop in doing testing for HIV and TB, such that when this was realized, it was a matter of then how do we ensure that this is improved? We cannot afford, because remember, we are always, when it comes to HIV, we always talk about we need to reach the 90 targets, where 90 people should know their status, 90 should be on treatment, 90% of those should be on treatment, and 90% of those should have viral suppression. But when, in fact, I was looking at the data, and it is showing that we have not reached those targets. And I mean, for the 90 we're sitting at 93 years. A lot of people know their status, but it's only 75% of individuals are on treatment. And of those, it's only 88% that are actually suppressed. So we need to bridge that gap. But what we have seen is, firstly, like I said, there was a reduction in testing, especially for TB. But what we saw is that as far as people who are on antiretroviral therapy, they have managed to maintain their treatment. But what this means for us as a country is that we need to be careful when there is any a pandemic or epidemic. We must never forget our health challenges, our health burden, and end up shifting all priorities to whatever is facing us at that point in time. And so it's important for us to ensure that we get into establishing comprehensive healthcare services. So right now, we really need to go back and say, how do we go back into ensuring that COVID testing falls into the full comprehensive basket of provision of healthcare. And it's not just going to be HIV and TB alone, but all the other non-communicable diseases as well. So really, it's important. I feel the frustration of the person who are speaking there, that really, as government, as the Department of Health, we need to ensure that when the budget, it must not really be just focusing on one particular emergency, but there's got to be distribution, so that we don't find ourselves as a country, just because we're faced with the pandemic, we lose all the other gains that we had insofar as TB and HIV programs are concerned.
I know I'm asking the obvious, but who does the buck stop with?
The buck stops with the Department of Health at the end of the day, because they need to ensure that the resources that are needed are available, and that then those resources are then distributed equitable to all the health needs of the country.
Professor Mlisana, thank you so much. I wish we had more time, but thank you so much for agreeing to talk to us this evening. Professor Mlisana, who is, of course, the government's chief advisor on COVID-19. After the break, we'll talk about the country's death rate. Don't go away. Welcome back. This is the Watchdog. We now speak to the South African Medical Research Council and the National Funeral Directors Association about the country's death rate. The South African Medical Research Council issuing a report that it says there is a bit of an undercounting of deaths in South Africa. We're joined by Dr. Lawrence Kwayana. Dr. Lawrence Kwayana, you are as the National Directors, Funeral Directors Association. What have been your observations about deaths in South Africa?
Well, good evening. We'll be receiving quite a lot of deaths. Unfortunately, most of them come as natural causes. Most families shy away from, registering death as COVID. Certainly, the numbers that we see indicated as COVID deaths, I think they are way underestimated compared to what we are seeing currently.
Mm-hmm. Professor Bradshaw, what From your information, what is happening? What is responsible for the underreporting on deaths?
Good evening, Vuyo, and to the viewers tonight. There's quite a challenge with the counting of COVID deaths. The Department of Health has a system where any death that occurs in a health facility, the information gets reported through the province to the national, and we get the official confirmed COVID deaths reported on a daily basis. However, when we look at the actual number of deaths that get registered in the country with the Department of Home Affairs, we've seen that they're much, much higher than what would have been expected had there been no COVID pandemic. And the difference between what is registered and what would have been expected, we are calling these excess deaths, and having tracked it for the last 18 months, nearly 2 years, we've come to the conclusion that most of those excess deaths are indeed COVID-related. They track the COVID pandemic very closely as it unfolds in each province. The number of excess deaths have gone up in the same timing as the COVID pandemic. So we think that about the confirmed deaths account for about 1/3 of the actual real deaths. So as you said, we're indicating that there is an undercount of official confirmed COVID deaths.
Dr. Eturalde, why is this important? Perhaps is the question I should ask you.
I think it's important to understand the magnitude of the impact that COVID-19 is having upon South African society. I think that, as Professor Bradshaw has just indicated, the processes that lead to the reporting of the 67,000 deaths so far, vis-a-vis the reporting of the excess deaths. I think it's an important initiative that StatSA supports because it gives us an overall picture of the impact of COVID-19.
Mm-hmm. Without which, what would happen?
Without which, we would have an incomplete picture of the amount of deaths that are occurring. We would have a situation where we are not understanding the age structure of deaths, the sex of deaths, where they're occurring, and it would make it very difficult for us to make any estimation on the size of the population in the absence of that information, which is far more complete.
Mm-hmm. Professor Bradshaw, who then do you give this information to, or who is it for?
We've been preparing these reports since March last year, and we make it available to the Department of Health, to the Minister of Health, who has been responsible for the response to COVID. But we put it out in the public because I think there are many agencies and people who want to know what's happening. So it's available on our website.
Dr. Kwayana, do your members also collate this kind of information?
Well, yes, we do. We do collect this information. Unfortunately, we never really get asked for it by any authorities.
But ideally, who would you give it to? Who do you think? aren't local authorities compiling this sort of information? Like local government authorities, I mean.
Well, we normally would send the death notifications to the Home Affairs, but in most cases, like I said, they come as natural causes, and because most of these people also, they have comorbidity as well. So, they come up as complications of hypertension or pneumonia. But when you go down, when you speak to the families, you'll really find out that it's probably due to COVID. And most people will just say it was flu, or they just point out they had one or two symptoms of COVID. And some of the families, actually, they don't even disclose, even when they know that the person has tested for COVID and was COVID positive. They don't disclose some of this information to us. You only find it out later. And the tests that are done, especially in public institutions, normally the families get the results way after death has occurred.
Professor Bradshaw, now I was in a conversation earlier with the government's chief advisor. She's the co-chairperson of the Inter-Ministerial Committee on COVID-19. Is it not perhaps an idea to, give them this, or maybe even if it means forcing your way through, but getting them to appreciate that you've generated this body of knowledge, or these numbers that they should take very, very, very seriously? Because otherwise, how else do they then get to prepare adequately, for the COVID-19 pandemic we all have to fight, if they don't have a true reflection of what is actually happening on the ground?
The Ministerial Advisory Committee that's chaired by Professor Mislana and Professor Jacobs, we do provide a report to them every week, and they share it with the members of the advisory committee. They need to look at our data, but also at the other information that's available. So the NICD also provides reports on the number of tests that have been done and the proportion of those tests that are positive. There are groups who are modeling and doing projections on the numbers of people who are infected, and sort of trying to extrapolate for each province and district what the numbers would be in the next few weeks. So our data, I do believe, is very important, but I don't think it's the only data that they should be looking at. They need to look at the whole picture.
Dr. Eturalde, I mean, you, as Stats SA, continue to generate reports on a frequent basis. And I remember from previous conversations with the current but also the former statistician general, there's always the complaint that you generate this information, but it doesn't get used by the people who have to take decisions.
Well, I think it's important to understand what the mandate of Statistics South Africa is. I think first and foremost, we are not a policy department, so we're not in a position to indicate to departments what policy stances need to be taken. But we collect the data. We, for example, in this past week, we've released the mid-year population estimates, which has used the data from the MRC to a huge extent in order to calculate indicators that were released in that report. And I think a report like that is an important report, which enables government to plan and to make interventions wherever necessary. There may be incidents where government may not be aware of data that has been released, but I think we go to a significant effort to make sure that this data is publicized widely and to indicate what its value is. I think at the CSIR and the Department of Science and Technology have established a national policy data observatory, and this observatory is interacting with the NatJoints and NCCC to ensure that data sources that we create, as well as research findings from other institutions, are finding themselves into the discussion rooms of these intergovernmental institutions that make the decisions at the end of the day.
I guess what I'm apparently asking is whether you, as people who generate information on a frequent basis, whether you found creative ways, perhaps, of getting decision makers to sit up and notice. Yes, it is not your responsibility to act on the information that you keep churning out, but even if it's to nudge them, have you found any creative ways of getting them to sit up and notice when you generate these reports?
I think that the communication and the publicity around Statistics South Africa produces is quite a sophisticated mechanism. I think that there are many intergovernmental forums where we share this. We share this publicly through our website and through social media, and I think that as to say we on a thematic basis we engage with various partners and we make them aware of what is about to be produced or what is being produced. So our partners in Home Affairs, in Health, in the Department of Labor, in the DPME, they're all very aware of the information that we are producing, and where we feel that data is being not taken notice of or being abused or being misinterpreted, we indicate that. The Statistician General has a responsibility in terms of the Statistics Act to ensure that that is the case, and we certainly do intervene when those instances take place.
Okay, that's all we're going to leave it. Thanks very much, all three of you, for coming through this evening. Special thanks to Dr. Goyana, Dr. Ituralde, as well as Professor Debbie Bradshaw, whose team has produced this report, which shows that the number of deaths rose for a fifth week here in South Africa to 10,000 in the week to July 17. This as the country is being hit by a third wave. Officially, South Africa is the nation worst hit by the coronavirus on the continent, with over 2.3 million confirmed infections. And that's where we're going to leave it this evening. To join us again tomorrow evening at 8 o'clock. From me and the team, have a good night.